Type 2 diabetes begins with insulin resistance, where cells in muscles, fat, and the liver don't respond properly to insulin. Initially, in a healthy individual, insulin binds to receptors on cell surfaces, triggering a signaling cascade. This allows glucose transporters called GLUT4 to move to the cell membrane, enabling glucose to enter the cell. In insulin resistance, cells in muscles, fat, and the liver don't respond properly to insulin. The pancreas compensates by producing more insulin. At the cellular level, insulin receptor signaling pathways become impaired, preventing glucose transporters from moving to cell membranes. Inflammatory cytokines like TNF-alpha interfere with insulin signaling, further impairing glucose uptake despite elevated insulin levels. Insulin resistance develops gradually due to several factors. Genetic predisposition plays a significant role in determining individual susceptibility. Excess weight, especially visceral fat around abdominal organs, releases inflammatory molecules that directly interfere with insulin signaling. A sedentary lifestyle reduces muscle metabolism and glucose uptake, contributing significantly to insulin resistance development. Let's examine the molecular mechanisms of insulin resistance. The insulin signaling pathway begins at the insulin receptor. Insulin receptor substrate proteins, or IRS, become impaired through serine phosphorylation, blocking proper signal transduction. This impairment disrupts the PI3K and ACACT signaling pathways, which are essential for proper glucose metabolism. Without proper activation of these pathways, GLUT4 glucose transporters cannot move to the cell membrane, preventing glucose uptake. Inflammatory cytokines like TNF-alpha and interleukin-6 further interfere with these signaling pathways, worsening insulin resistance. The end result is reduced glucose uptake by cells despite normal or elevated insulin levels, leading to hyperglycemia, the hallmark of type 2 diabetes. In the progression of insulin resistance, the pancreatic beta cells initially respond by increasing insulin production. As insulin resistance progresses, beta cells compensate by producing more insulin to maintain normal blood glucose levels. However, this compensation eventually fails as beta cells become exhausted and dysfunctional. Several mechanisms contribute to beta cell failure. Firstly, glucotoxicity. Chronic high glucose levels directly damage beta cells. Secondly, lipotoxicity occurs when elevated free fatty acids in the bloodstream cause beta cell apoptosis or programmed cell death. Amyloid deposition in pancreatic islets forms abnormal protein aggregates that disrupt normal beta cell function. Oxidative stress generates free radicals that damage cellular components and accelerate beta cell deterioration. Finally, endoplasmic reticulum stress occurs when the cell's protein folding machinery becomes overwhelmed, triggering cell death pathways. These stressors lead to progressive beta cell deterioration, moving from compensation to stress, failure, and ultimately cell death through apoptosis. As this process continues, beta cell mass gradually decreases, with fewer cells remaining to produce insulin. This creates a vicious cycle where declining insulin production worsens hyperglycemia, further damaging the remaining beta cells. This progressive beta cell dysfunction explains why type 2 diabetes typically worsens over time, often requiring escalating treatment approaches. Understanding beta cell dysfunction is crucial for developing new therapeutic approaches that can preserve or restore beta cell function in type 2 diabetes. The combination of insulin resistance and beta cell dysfunction leads to multiple metabolic disturbances throughout the body. These two major defects create a cascade of metabolic consequences that affect multiple organ systems. Let's examine how three key tissues are affected: the liver, adipose tissue, and skeletal muscle. In the liver, insulin resistance has a profound effect on glucose metabolism. Normally, insulin suppresses gluconeogenesis, the process by which the liver produces glucose. However, in an insulin-resistant state, the liver fails to suppress gluconeogenesis, leading to continued glucose production even when it's not needed. This unchecked glucose production contributes significantly to fasting hyperglycemia, a hallmark of type 2 diabetes. In adipose tissue, insulin resistance disrupts normal fat metabolism. Normally, insulin suppresses lipolysis, the process by which stored fat is broken down and released into the bloodstream. In an insulin-resistant state, this suppression fails, leading to increased lipolysis and the release of free fatty acids into circulation. This creates a vicious cycle called lipotoxicity, where free fatty acids worsen insulin resistance, leading to more lipolysis and further metabolic dysfunction. Skeletal muscle is the primary site of insulin-stimulated glucose disposal in the body. Normally, insulin promotes glucose uptake into muscle cells and stimulates glycogen synthesis, storing glucose for future energy needs. In insulin-resistant muscle, glucose transporters fail to respond properly to insulin signaling, resulting in decreased glucose uptake and reduced glycogen synthesis. Since skeletal muscle accounts for approximately 70 to 80% of insulin-stimulated glucose disposal, muscle insulin resistance significantly contributes to elevated blood glucose levels. Metabolic dysfunction triggers chronic low-grade inflammation and oxidative stress, creating a system-wide impact. The combination of hyperglycemia, dyslipidemia, and excess adiposity creates a pro-inflammatory environment characterized by increased cytokine production. This inflammatory state involves multiple mechanisms, including endoplasmic reticulum stress and adipose tissue dysfunction, that perpetuate and worsen metabolic derangements. This systemic inflammation creates a vicious cycle that worsens insulin resistance, accelerates beta cell failure, causes endothelial dysfunction, and significantly contributes to diabetic complications. Chronic hyperglycemia and metabolic dysfunction lead to serious long-term complications affecting multiple organ systems. These complications develop through several molecular mechanisms, including the formation of advanced glycation end products, activation of protein kinase C, and increased flux through the polyol and hexosamine pathways. These molecular changes cause pathological alterations in tissues, including damage to both small and large blood vessels, thickening of basement membranes, nerve demyelination, and widespread endothelial dysfunction. The clinical manifestations include cardiovascular disease, the leading cause of mortality in diabetes, diabetic nephropathy, which is the leading cause of kidney failure in developed countries, diabetic retinopathy, which can lead to vision loss and blindness, diabetic neuropathy, causing pain, numbness, and increasing the risk of foot ulcers and amputations, and cerebrovascular disease, increasing the risk of stroke and vascular dementia. Importantly, these complications are interconnected, with dysfunction in one system often accelerating damage in others, creating a cascade of worsening health outcomes. Understanding these systemic effects and their interconnected nature is crucial for the effective prevention and management of type 2 diabetes and its complications.